Hi, Lawrence LeBrocq, Managing Partner and CEO of Garces, Grabler and LeBrocq, GGL Wins. Welcome to the podcast, The Authority in Personal Injury. And today we have as our guest, Dr. Wayne Fleischhacker. How you doing today, Wayne?
Doing great.
Dr. Wayne Fleischhacker is an authority in the industry. He's double board certified in anesthesiology and pain management. He was formerly trained as an osteopathic doctor, and I'll let him explain what exactly a doctor of osteopathy is and what it means to be double boarded and trained in both pain management and anesthesiology. Hi, Doc. Tell us a little bit about your credentials and background.
Sure. Hi. Thanks for having me. I'm a DO, as you said. I went to an osteopathic medical college, the New York College of Osteopathic Medicine. I did my anesthesia and pain training at Temple University. My practice deals with patients who have chronic pain, neck and back. Patients usually refer to our practice after trying other forms of treatment for their pain, and we do a thorough evaluation, review MRI images, CAT scans, X-rays, perform a physical exam, and then usually come up with a treatment plan for these patients who are suffering for a long period of time.
And I want to warn you ahead of time, Doctor, that a lot of the defense lawyers are watching this podcast, and they're going to use whatever you say here in a courtroom. Not that you're going to say anything that you have to worry about, but it's just amazing that they're actually digging into these podcasts and watching the doctors on the podcast so they could try to cross-examine them on the podcast. So that being said, let's talk a little bit about what is anesthesiology.
So anesthesiology is a medical specialty. Most people know what an anesthesiologist is. Anybody who's ever had a surgery, the doctor who puts you to sleep and wakes you back up. But there's also subspecialties in certain medical fields, one of them being anesthesiology. And I have additional training in what we call interventional pain management. So as a subspecialty of anesthesiology, I'm board certified in taking care of patients with spinal pain, performing different types of invasive procedures, injections, diagnostic tests, minimally invasive surgery, and also assisting in major surgery.
So let's talk a little bit about the techniques used to relieve pain as a pain management doctor. And there's so many different techniques. Let's just go through the list a little bit and what the reason is. Now, we've all heard about epidurals. The defense loves to call them injections, but what is actually an epidural and why is that performed?
So when we evaluate a patient, we're looking to try and find out why they're in pain, why they're still in pain despite having other types of treatment. They may have been to a chiropractor, they may have seen a physical therapist, they may have had acupuncture, taken anti-inflammatories, muscle relaxants, and just time in itself, in a lot of these cases, heals injuries. But by the time the patient gets to us, they've pretty much exhausted those what we call conservative measures. When we evaluate a patient, we'll take a history. As I said, they'll come in with perhaps neck or back pain, maybe both. They may or may not have associated symptoms such as headaches, radiating pain to their arms or their legs. They may describe a shooting sensation, an electrical sensation, a nagging pain, numbness, tingling, maybe weakness. Most people know the term sciatica. Sciatica is a pain that starts in your lower back, goes through your buttock and down your leg. And these represent these types of symptoms: numbness, tingling, nagging pain, aching, electrical shocks, lightning bolts. Indicates typically that a nerve from your spine is being irritated, is inflamed, and as a result, there's pain along the distribution or the path of that nerve, and it goes all the way down your leg into your foot sometimes. So the reason why that pain exists is that there's some sort of an irritant. It may be a bulging disc, a herniated disc. Those are usually the things that are going to cause these types of problems. There are other things that are a little less common. But if we talk about that for a moment, why do we do an epidural? An epidural is just the name of a procedure. It's a place in your body, the epidural space, that is a small little area that is just outside the cover of the spinal cord, which is called the dura. So the word epi means outside, dura. epidural. So outside the spinal cord cover is an area that we can identify. We can enter that area with a needle utilizing an x-ray machine. And we can inject a medication into that area, typically a steroid or a cortisone, which acts as an anti-inflammatory. And that takes away, hopefully, the inflammation of the nerve that is causing the sciatica or the radiating pain. And similarly, we can do this in the neck, and we can do it in the middle of the spine as well, where your ribs are. So an epidural steroid injection is simply an injection that goes into the epidural space, giving a steroid or also a cortisone, same thing, just different names, as an anti-inflammatory.
Now, that doesn't cure the problem. It will alleviate the pain, but if it's caused from a bulging or herniated disc, which I'll let you explain what those are, it won't cure the underlying bulge or herniation.
Correct. The purpose of the procedure is to reduce the inflammation that is being caused by the pathology, either a disc bulge or a disc herniation. You don't always have to fix the disc bulge or the herniation. You have to get rid of the inflammation. A lot of people are walking around with painless discs. They get an injection or they take an anti-inflammatory and it reduces the inflammation and you can function. Not every disc needs to be fixed.
All right. So now we hear about facet blocks and facet injuries. What is that?
Okay. So on your spine, you have joints on the back part of your spine where the bones connect. Each of the vertebrae, which are like little blocks, starting from the base of your skull all the way down to your lower back, there are vertebrae. And those bones have to connect to each other. And those are connected on the back side of your spine by what we call a facet joint. Now, if you have an injury to your back, let's say a rear end collision where you're thrown forward, thrown back, you can literally sprain your back or your neck just like you can sprain your ankle or any other joint. And you can develop inflammation in those joints, and that can create pain that is what we call axial, meaning it's non-radiating. So somebody with a facet problem doesn't complain of pain radiating down their arm or their leg with numbness and tingling. That would be a nerve irritation, as we spoke about before. Facet pain is pain that is typically associated with pure neck or back pain without radiation. It's typically worse in the morning. It's worse with stationary positions, going from a sitting to a standing position. First thing in the morning when you get out of bed, you feel real stiff. You feel a little bit better when you start moving around, take a hot shower, whatever it may be. But those joints, if they are inflamed and not improving, we can do a cortisone shot into the joint, just like you would have a joint injection in your shoulder or your knee if you had arthritis. And again, acting as an anti-inflammatory to reduce the inflammation in those joints. The other method for treating those joints is doing what we call a radio frequency ablation. These joints have nerves called medial branch nerves that innervate them and send a message to your brain that they hurt. We can numb that nerve, make sure that it takes away the pain. That's a diagnostic test. If that's successful, then we can use a special needle, touch that nerve with that needle where the tip heats up, and we actually cauterize or burn that nerve to disconnect the wire, so to speak, so the message of pain can't get to your brain. And that typically provides pain relief for a period of time, on average roughly a year. But that nerve, being a peripheral nerve, can regenerate, can grow back together, and the pain then can reoccur.
That's amazing because, before I got into this industry, I didn't realize that you could actually regenerate a nerve, like a nerve could grow back, because you hear about paralysis and spinal cord injuries where they don't regenerate, but the peripheral nerves will.
Correct. Correct.
So now you do a lot of pain management. I know you've been the head of pain management at Union Hospital. Now, there's a difference between treating somebody for pain management that's suffering from a chronic disease like cancer pain and somebody who's in a traumatic event. Could you describe the differences in the techniques and what's used?
Yeah, again, the source of the pain, how it began, is important, but the treatment is often the same. So if I have a patient who has a traumatic event, a sports injury, a car accident, a fall down, and they herniate a disc as a result of that, they're going to have sciatica. If somebody has bad spinal stenosis, they're elderly, and they have a tightening or a pinching of a nerve that's going down the leg, it's actually the same complaint. It's just a different reason. As far as the treatment, they are the same in a lot of the cases. But again, we're talking about patients who have bad arthritis. If they're elderly, we may not be able to get into the area of the spine because of bony overgrowth, and we have to change the technique. Fortunately, we have about 3 different ways of accessing the spine. One is what we call an interlaminar approach. Another is called a transforaminal approach. And then we have a caudal approach. So we have different ways of providing medication. Some work for some and some work for others. But at least we have a couple of tricks or tools in our bag that we can use to try and solve the problem. For those patients who don't get better, then we have other more advanced techniques and options for them.
So before we get into the more advanced techniques, let's talk a little bit about if somebody is injured and for them to get their bills paid. Let's say somebody is injured in a trip and fall type of case or a construction case. Now, if they're not working, they're going to have to use their medical insurance for those types of injuries. And then there's a different care path, somewhat different, for a person that is injured in an automobile collision, because you have to follow the care paths aligned by the court for the treatment of specific injuries. Could you just, how do you manipulate that, or how do you follow the different care paths?
So personally, as a physician, when you come to see me and you walk through my door and you have a complaint, obviously the insurance and those sorts of things on the back end or the front end, however you want to look at it, are important. The doctor has to get paid. We're running a business like anybody else. We have staff, we have expenses, rent, all these kinds of things. So yes, the money side as far as getting paid is important. I try to focus primarily on the care of the patient and let the staff and the people that we hire to do that sort of stuff do that as far as their business or their day-to-day activities. But as you're saying, we have what we call care paths. If I recommend to somebody to have an epidural steroid injection, they need to have had to have gone through the appropriate steps before they got to me as far as trying conservative care. So that means, some medication, perhaps an anti-inflammatory or muscle relaxant, that they saw a chiropractor or they saw physical therapy. We need to have about 4 to 6 weeks of conservative treatment before we can get an authorization for a more invasive type of treatment, such as an epidural. Now, there are cases where those other types of treatments are not indicated. Somebody who has a neurological injury, a foot drop as an example, or something more emergent. We would skip those other steps because we know that that's going to ultimately do harm to the patient if we delay. But the process for us to treat a patient is somewhat complicated, and the steps that we have to go through are: number one, we have to see the patient in the office. We have to verify their benefits or insurance. If we're going to treat the patient beyond just a visit, we then have to go through a pre-authorization process, where we have to submit our notes and our records and findings as far as MRIs and those sorts of things to the insurance company and request an authorization to perform the treatment. Quite often, we run into barriers with getting these authorizations based upon, let's call it, a difference of opinion. I think the patient needs something, but the insurance company, for whatever reason, doesn't think they need that treatment. They may be sent to what they call an independent medical evaluation, which would be to see a doctor who is working with the insurance company to evaluate the patient themselves. If that doctor doesn't believe, for whatever reason, that the recommendation that I've made or another physician has made, then they will send back a denial. Then that triggers another process. Now I have to submit an appeal with an explanation as to why I believe what I originally thought was necessary is necessary. That appeal may or may not be accepted. They may continue to deny the care, or they may overturn it. Fortunately, when it comes to personal injury, we as physicians have the ability to proceed despite the insurance company's denial, and we can go through an arbitration process and get the patient the care they need. And then down the road, several months to a year or two even, we'll get in front of an arbitrator who will determine if the treatment that I recommended was appropriate and necessary and causally related to the injury that we're treating them for. So there's a number of steps. It takes a lot of staff. It takes a lot of time. But our goal is most importantly to take care of the patient.
Which is a great goal, and that's the goal that every doctor should have. Unfortunately, some of these defense doctors that are being paid by the insurance company, their goal is not to let the people get treated appropriately because it costs them more money. And they're answering, unfortunately, to an insurance company and not a person. So let's say now a person that you're treating, and we all know you have a fantastic reputation, but let's just say that this herniated disc that's causing the radiating pain down a person's leg, known as sciatica, is not responding to the epidural treatment. You tried a radiofrequency ablation and this person is still suffering. What is then the recommendation for that person?
Yeah, when we are unable to provide the relief that we had hoped, those percentage of patients, which fortunately is small, have to go on to get a surgical evaluation. So we have, we know a lot of the doctors in the area; they're all excellent. We would refer the patient to get an opinion. Now, obviously, the best surgery is no surgery, and the next best surgery is the least amount of surgery. And I tell my patients that, but. And they're obviously apprehensive, and most people are nervous. Nobody's in a big rush to go out and get a spine surgery. But when somebody needs a surgery and they go through the surgery, you know that person has been in a lot of pain for a long time to make that decision to proceed.
And now, doctor, you said that you perform some minimally invasive procedures and that you assist on some of the larger surgeries. Could you explain what some of those minimally invasive procedures are and what the purpose of those procedures are?
Yeah, as a pain management physician, I'm trained to perform what we call percutaneous or minimally invasive surgeries, such as discectomy. So let me back up a step. I'm going to tell you what a disc itself, how it's designed, and its purpose.
And doctor, I noticed over your right shoulder, you were talking about facet joints, and I was laughing. You have a model with all the facet joints right there over your right shoulder.
I could bring it up and show you if you'd like, but regarding the types of surgeries that we do, the minimally invasive percutaneous procedures. So we are trained to access a disc. What I mean by that is we can take a needle and we can lay you on your belly and we can use an X-ray machine and we can actually pass a needle from your spine, through your skin, through your muscles, down into your disc. The disc is, I describe it as a jelly donut, essentially. It's got a firm outside where the dough would be, called the annulus, and it has a soft jelly, kind of crab meat type of material on the inside where the jelly of the donut would be. A disc bulge, we've talked about that, is when the dough of the donut becomes weakened and it allows that disc to expand beyond the borders of the vertebral bodies above and below. And that can cause an irritation of the nerves, a tightening around the nerve, and it can cause what we call stenosis, and that can result in
And you have assisted on those types of surgeries as well.
many, many times.
And then that fusion, if it's a low back fusion or what we call the lumbar spine, what is the normal recovery period of a fusion?
Tell patients that you're not fully healed. What we mean by healed is fused, generally 6 months to a year.
Right. And then a minimally invasive discectomy, what is the recovery period for that type of surgery?
Probably a week or two.
Yeah, so it's a huge undergoing to have your low back fused, and it's a very intense and prolonged recovery period from that type of surgery.
Yeah, and sadly, there's a population of patients who have this done who end up coming back to me who have what we call failed back or post-laminectomy syndrome, and they just never get better.
Right.
Despite excellent surgery. I mean, everything looks great on the CAT scans, on the x-rays, everything is in the right place, and they just have chronic pain at that point, which then, in a lot of cases will offer what we call a spinal cord stimulator, which is another device or treatment that we offer patients where they just, they just, there's no more surgery that can help them, or they just don't want to go on to have more surgery. Or there may be health factors that prevent them from having surgery. And a lot of this is due to scar tissue that develops in the area, which you have no control over. It's not something that you can remove, because if you remove it, it's just going to come back potentially worse. So in these situations, it's pretty dire, and patients then can be offered what we call spinal cord stimulation. And that is a procedure that we as pain doctors are trained to do. Where we place a wire or two up into the epidural space in the back. And how I explain it to my patients is that this stimulation, the nerve tracts that